Hello, everyone. I'm Caroline Blum from NCQA, and I'm here to talk today about person-driven outcomes, a new approach to quality measurement for complex patients. We want to start out by thanking our funders. This project has been developed with generous funding from the John A. Hartford Foundation and the SCAN Foundation. I'm going to be talking about person-driven outcomes. So we'll start to really sort of focus on what does this mean. Person-driven outcomes measure what matters most. They are outcomes identified by an individual or a caregiver, depending on whether the individual needs or wants help. So outcomes identified by the individual as important that can be used for care planning and quality measurement. This slide I'm going to spend a little time on. This slide is a model of how person-driven outcomes intertwine with the clinical delivery of care. We call this the person-driven outcomes approach. And I myself am a geriatrician and a palliative care physician, and I really like person-driven outcomes because they're a way of measuring care and quality of care at the time of clinical delivery of care. And this is what I mean. Look at the first box. It says elicits what's important. Clinically, the clinician elicits from the patient what's important to them. But then the second box, the patient's goals are standardized. So the clinician helps the patient identify, and then the clinician measures the person-driven outcome. NCQA has identified 2 ways to standardize this measurement: through person-driven reported outcome measures and through goal attainment scaling. And I'll talk a little bit more about that in the coming slides. Then we go back to the clinical world. The clinician and the patient together come up with a plan to help the patient achieve their person-driven outcome. Then in follow-up, this gets reassessed. How is the person doing? And finally, the last measure is to whether the person has improved or achieved their person-driven outcome, or maybe made progress. And in some of our frail elders, achieving the measure can actually be maintaining their current function or their current outcome that's important to them. So I think this approach is very flexible and really achieves measurement and clinical integration. The next few slides are going to tell you a little bit of the detail of how we actually go about doing this. And this is just a screenshot of one of the measurement ways that NCQA developed when we tested this, that I'll be telling you about in a few minutes. One of them is by eliciting what's important. The person will come up with some goals, and NCQA had developed through focus groups some goals that people often had, but person could make up their own, and the person could select that goal. And then after the person select a goal or an outcome that means something to them, that's synonymous, the goal or the outcome that means something to them, outcome that matters, there are 2 options for the clinician to standardize that so that it can be tracked and measured. Option 1 would use an existing PROM outcome, and option 2 would be to develop a new outcome using a process called goal attainment scaling. And the next few slides are going to talk about that in some detail. So if the clinician decides to use a PROM, this shows how they could translate the person-reported outcome to fit a PROM. And the participants, the clinicians, are able to choose from a bank of these PROM, which stands for patient-reported outcome measures. For example, here's if a participant goal is to relieve their back pain so they can do their woodwork, the type of PROM that would be selected, and this is a standardized patient-reported outcome instrument, they could select one about pain interfering with daily activities. If you jump to the bottom, if the patient's goal is to plant a garden this spring, the clinician, the patient could select a PROM that measures physical functioning. And for example, if the patient wanted to regain strength and endurance so they could fish, the clinician could select a patient-reported outcome measure of mobility. The second way is goal attainment scaling, which I'm going to show you on the next slide. So goal attainment scaling is a bit more flexible, takes a bit more clinician training. But for an example, if we had an 89-year-old woman who had 6 deficits in activities of daily living. She had dementia, depression, history of substance abuse and arthritis, multiple chronic conditions, frail elder, exactly the type of person these measures were designed for. If she and her caregiver set a goal to go outside once the next 3 months, this could be scaled. So the way we would do that is -1 is where she is now. Go to So that's her current state where she's not doing anything right now. But if she gets a little bit better, she can go outside once in the next 3 months, or she could even get better than that, go outside more often. So you can see this is where they want to be. Now, of course, if the person didn't achieve the goal, they could be worse. So now I'm going to sort of change, tell you a little bit about the testing that NCQA has done with the person-driven outcomes approach. So over some years, NCQA has done developing and testing of person-driven outcomes in 3 stages, really. The first stage was a pilot in complex care sites. And that was done 2015 to 2017. Was a prospective pilot study, really for feasibility to make sure this could be done, but 2 papers have been published based on that. A much bigger test came from 2018 to 2020, where there was a demonstration of this process, the person-driven outcomes approach, in some complex care sites. There were about 8 sites were done, and I'll talk a little bit more about the results. And finally, we're in the new phase, implementation and dissemination phase from 2021 to 24. And in that one, we're going to prioritize and figure out how to disseminate these, create more demand for the measures, and increase clinician and delivery acceptance. Here are the proposed person-driven outcome measures that NCQA had developed through its project, through its pilot, and then through the demonstration project. The first one is assessment of a person-driven outcome. The second one is follow-up of a person-driven outcome. And the third one is achievement of the person-driven outcome. Just like any measure, they have a numerator and a denominator. And the denominator, which is important, and as I said, these measures were designed for people with complex care needs, and that, in fact, is the denominator. The numerator would be whether the people achieved the measures. So from the all the testing that NCQA has done, the pilot from 2015 to 2017, the functional disability project from 2018 to 20, and serious illness projects from 2018 to 2020. So these are the major tests of these, and you can see that they were tested in multiple different types of care delivery system where people with complex care get their care. They were tested with multiple different types of clinicians and multiple different types of patients. I'm going to go through this in a little bit of detail because this is part of the strength of these measures. They were tested in Medicare case management in long-term services and support area. Generally, the clinician was a social worker or a case manager or maybe a nurse. They're tested in special needs plans, Medicare and Medicaid plans, and even in a behavioral health Medicaid plan that actually had younger people with mental illness. The second place they were tested is in case management in complex care patients. So this is, for example, in Medicare Advantage plans with their complex patients, in an integrated delivery system, even an accountable care organization. Finally tested in geriatrics primary care, hospice, and serious illness programs, which are home visit programs for people with serious illnesses. But you can see multiple clinicians and lots of different types of patients, and the clinicians from physicians to social workers to nurses. Really a very strong test, and over 1,300 patients have been involved. So we have some results, and the measures behave like measures. There was variability among sites in measure performance. The other very interesting thing with all the 73 or so clinicians that did this and the 1,300 patients, the patients and the clinicians could figure out how to do this. They did it. We got measure results. I will note, if you might remember, that there were 3 measures. The first measure, which is to elicit the person-driven outcome. All the patients at the sites where this was tested were eligible for this measure. So there was we didn't test the first measure because everybody was eligible. We didn't have to determine eligibility, but we certainly tested the second two, follow-up and achievement. And you can see in the 4 functional disability sites and in the 4 serious illness sites, there was a range of follow-up. There was also a range of achievement of the goals. For the functional disability site, we had some claims and we have some surveys, and we are still analyzing the data, but we are getting a signal showing that perhaps hospitalization and ER visits may be decreased in people who participated in person-driven outcomes. We also spent a lot of time getting qualitative findings. We talked to the NCQA staff, talked to patients and caregivers, clinicians, and even administration and leadership. And basically, the patients appreciated the experience. Many times it was the first time they were even asked what mattered to them or what they really wanted, what their goals were. The clinicians felt they better understood their patients' preferences, but they had a little bit of mixed reactions to time, the way this was set up, because it was the initial project and really a research project. It was separate from their workflow, so they were a little bit concerned about that. But they did feel the approach offered accountability and aligned with other clinical markers, and many of them said this is what they'd rather be doing than just checking off boxes on some of the measures. Towards the end of the person-driven outcome demonstration project, NCQA organized a group of stakeholders, and these stakeholders were policymakers, researchers, clinicians, people who represented the types of programs where this was tested. And they presented the results and really got stakeholder recommendations on how to move forward, how to disseminate this, how do we get them widely used. And I think it's very interesting to take the advice of the stakeholders and see what they said. The first thing they said is value and payment. If you want person-driven outcome measures to get used, you have to align payment to these outcomes, and you have to streamline the measures to prioritize goal-based care. So pay people to do it, first thing. The second thing was the second big advice, and these are the next 2 boxes about leading change and changing roles and culture. Asking patient what matters to them and what their goals are is really a culture change. And even though many types of care for complex personalities sort of give lip service to it, ask the goals, look for the barriers to the goals, for example, very rarely do clinicians feel they've been trained to do this correctly, and patients actually often don't even perceive they're being asked about the goals or what matters to them. So this is a culture change, and NCQA really has to build support among stakeholders. We have to look at how this the type of messaging that is meaningful and resonates with diverse populations, and we have to involve families, caregivers, and decision makers to really think about how we can get this disseminated. And finally, addressing the issues for the clinicians. The clinicians generally liked this, but they were worried that they didn't quite know how to do it. They required training, and it didn't fit into their workflow. So the second big thing, the third big goal are tools and training and workflow. Streamline the workflow and integrate outcomes with whatever data system they're using for their regular care. So based on the stakeholder recommendations and based on what NCQA felt was important to move this forward, we're now starting a new phase about implementing and disseminating person-driven outcomes, trying really to get them used. And there are 3 big parts of this. And you'll recognize this very similar to what the stakeholders said had to happen. On the box on your left says prioritize and implement pathways to widespread use of person-driven outcomes. And what this will be in the NCQA world is to try to get these as part of NCQA measurement systems or accreditation systems and NCQA programs that are widely used and highly respected, and have these measures be part of them, and that'll get them disseminated. The second box is about create demand for person-driven outcomes through a robust communication strategy. And that's really two-pronged. One way is to talk to decision makers, such as state Medicaid directors, health plan CMOs, and quality people, delivery system quality people, and say, this is a really good measure. It's good for your patients, it engages the patients, it's the type of care for complex patients, and really get a message that resonates with different types of people. We also, through our communication strategy, want to make sure that our messaging resonates, again, with diverse populations. And the third prong of the next steps is to provide technical assistance to the clinicians. Provide training materials, technical assistance, try to fit this into clinical workflow so that the clinicians are comfortable doing the kind of care they really want to do. And the next few slides speak a little bit to the dissemination within NCQA's programs and products, because this is the way that not only do they get used widely, but they also get put into health plan or health system or delivery system accreditation programs, and people get paid for doing this. So one big program that NCQA has is something called long-term services and support accreditation. And there are many states in the country that do this, several Medicaid plans from different states, multiple community-based organizations. So that's one big place where NCQA has a relevant program. A second big place is our person-centered recognition program for primary care and specialty care. And many of you know that as the patient-centered medical home. And in both of these types of places, the care planning process, or the CARE, encourages individualized case management, development of goals, development of patient preferences, and identification of barriers to goals. But again, clinicians often tell us they don't feel that they have been trained, they don't really have good tools to do this. And so our person-driven outcome measures really give them a standardized way to address these goals even better within these programs. NCQA also may be having new programs in the future as different types of care becomes important with the advent of COVID. So much more care may be switching to the home, trying to keep people out of both skilled nursing home and long-term nursing homes. So we'd like to include person-driven outcomes in potential new NCQA products and programs. One of the things that NCQA is thinking about is working more closely with age-friendly health systems, where that, again, what matters is one of the 4 M's, and of course our person-driven outcome measures certainly measure what matters. Other areas are increasing home care, the PACE programs and serious illness programs, and other delivery systems that that take care of people with complex care. And it's a little wonky. We also want to get NQX endorsement, because endorsement through the National Quality Forum allows this measure to be picked up, for example, by CMS or by other accreditation programs. It sort of gets a quote unquote seal of approval. So I want to acknowledge our team at NCQA that's been working on this for many of them for quite a few years. Thanks a lot for listening. I hope you enjoyed the presentation and got some insight into a new and we think better way of measuring quality of care for complex patients. Thank you.